and I don't have it set up here, but we can rotate this 360 degrees, we can tumble it, we can look at it from every angle. And it's like a model is being made of the child's head. And the computer goes in and takes all this pixel data. And what you can see is, you can see the little crack coming across here? So this child, indeed, did have a skull fracture, a non-displaced parietal skull fracture. So a lot of times, when you send me stuff to look at, or any expert, and you'll send me the CT scan, depending on which hospital they went to, if they don't do this reconstruction, we're a bit of a disadvantage. I can just tell you what I see. I can't tell you what I don't see. If they do the reconstruction, you know, it's very impressive on how we can be much more assured of what we're trying to determine. So I want to talk a little bit about accidental trauma. Things that we would call the normal, a child walking in the office falls down, is this abuse? These are some of the classic things that we see. The spiral fracture, I'm going to show you in a second. The key there is the intact fibula. There are two bones in the lower leg. In fact, I should have it here. Hopefully, there it is. There are two bones in the lower leg. This is a tibia, and this is the fibula. I'm testing myself. That's the tibia. And then this, it looks like two lines, but it's not two lines. It's a spiral. It's just like a barber pole. The way you can think of it is, you know, the cardboard tube that's inside a roll of paper towel? Next time you finish that roll of paper towel, take the cardboard tube and twist it, and you'll see the spiral open up, and it looks just like this as it opens up. Interesting, you see the distal point to the outside? What that tells us is this was an external rotation force to this limb. And that's the most common, in other words, foot going to the outside. That's the most common mechanism of injury for a toddler fracture. So it's a kid going down the slide, catches his foot on the edge, twists, and then he won't walk. Mom brings him in, we see this on x-ray, we put him in a cast, and 2.5 weeks later he's running all over the place. So toddler's fractures are very, very common, but the key is not only the spiral component of this, but also the fact that the fibula is intact. If you are going to abuse a child and shake them, twist them with enough force, chances are both bones will become affected as opposed to only one. Torus fractures, the distal radius, little bending moments, very, very common. A torus fracture always occurs 1 finger breadth back from the growth plate, and it comes from a fall and an outstretched hand. Very hard to do that in an abusive way, to hold the wrist just right to get that fulcrum in the right place. So when we see a classic torus fracture, it usually means it's accidental. And the supracondylar, we see especially in the kids that are running around, that comes from hyperextension of the elbow. And as the point of the elbow comes around, it acts like a fulcrum and causes the fracture. The ones that are not accidental are the ones that are higher up as rotations, and that somebody has pulled on it. So we look for those things to differentiate. And sometimes they're hard to see. They may be occult, meaning we can't find them, and the follow-up scans are very, very helpful. I want to talk real briefly about hematomas, okay, and specifically subdural hematomas. And I know your first question is, what's an orthopedic surgeon doing talking about stuff around the brain? Because orthopedic surgeons do have brains, much less my internal medicine colleagues would argue. But it's all part and parcel of the traumatic episodes that we see and evaluate every single day in our business. There are 3 layers of lining to the brain. There's what's called the dura mater, which is the very heavy layer, the arachnoid, which is very, very thin, and the pia, which sits right on the brain itself. And the bleeding tends to occur in a subarachnoid, beneath the arachnoid. We call that the subarachnoid space, or subarachnoid hemorrhage. That's what you'll read about all the time. It has these little spidery veins. Those veins are very susceptible to motion. We break hematomas up into 2 main types, one called an epidural and one called a subdural. And the dura is just one of those linings. So the epidural occurs outside of the dura and usually comes from a fall and fracture. The subdural hematoma, which is beneath the dura, usually in that layer or subarachnoid layer, and is caused from bleeding from these veins. And it can typically be associated with accelerations and deceleration, maybe acute or chronic. But interestingly enough, there are entities of spontaneous subdural hematomas or subarachnoid hemorrhages, most commonly associated with meningitis. So if you have a child who's been sick in the hospital with meningitis and later gets diagnosed as having a subarachnoid bleed, that's a great question to bring up. How do we know it was trauma and it wasn't just the meningitis? So those are just food for thought. Within the brain, we talk about bleeding within the brain, and that can be devastating to the child. Those are the things that cause swelling of the brain we call cerebral edema. So this is, when we get a CT scan, this is an idea. Now this is a different window. This is a tissue window on a CT scan. And you see the dark area on the very top? That's blood. And that blood sits inside. And we can go a step further and get MRIs. Remember the difference between a CT and an MRI? MRIs require general anesthesia. And so you have a child with head trauma, most of us, with the probably exception of Loma Linda, who doesn't think on everybody, most of us are very reticent to give a child with head trauma a general anesthetic. Because if they do have some cerebral edema or intracranial problems, it can be a devastating complication. So that's why you see CT scans commonly done first, and sometimes we'll do an MRI down the line. Because this, by the way, this is an MRI, and you see the white, because of the water densities, but that's blood. And you can tell, and in this particular, you see a water density of blood, and you see a darker layer underneath. These are two different bleeds. The white bleed is the acute bleed, the dark bleed is the older bleed. This, again, is devastating information. You have different layers of bleeding around the brain. That's usually a very, very poor prognosis, and typically is associated tremendously with abuse. And you can see in this particular case, these are old bleeds because the brain has been shrunken down within the skull. So this is one of those devastating problems. Shaken baby syndrome. I get asked a lot about shaken baby syndrome. I can tell you classically involves, the classic definition involves three things: subdural hematoma, retinal hemorrhaging, and cerebral or spinal cord edema. That's classic shaken baby syndrome. That's not typically what it gets morphed into now. Morphed into now, shaken baby gets associated with all kinds of other issues, such as the rib fractures, metaphyseal corner fractures, blunt abdominal trauma. By the way, we always do lab. If anybody sends me information on a patient, I always want to know the lab. And I'm looking for in the lab the enzymes, the abdominal enzymes. Is there evidence that the liver was injured or squeezed, or the pancreas, some of the sensitive organs that make all these different enzymes that we look at. So the classic shaken baby first described really in 1972, about 60% involved males, most common under 1 year of age. And of course, we need to rule out possibilities of other sources of bleeding, like hemophilia or other factors. And again, this is acceleration, deceleration. You hear us talk about this a lot. It's a shearing, and that's typically what causes it. And it's that pressure waves which cause the retinal hemorrhaging within the brain, and it's what causes the cerebral edema and disruption of tissue. Bruising. I get asked a lot about bruising. Bruising is one of the more nebulous things. I can tell you, by the way, how many of you are parents? Okay. Every kid bruises. Every kid. If they truly put people, if there was a bruising jail, we'd all go to bruising jail as parents. My son Tommy had 5 casts on before he was age 10. Luckily, I'm a mandated reporter, but I didn't report myself. But he would do intelligent things, like he'd stack up 3 chairs to dunk a basketball one time and kind of forget he had to land. And come limping in, and my wife would say, "What was he thinking?" I said, "You just hit the operative word right there." Thinking. So kids bruise. If you see a pattern to a bruise, i.e. a belt pattern, a rope pattern, a thumbprint pattern, that's a whole different meaning. Most of the time, what we look at is we want to look at from an aging standpoint. And bruises age over time, especially in Caucasian skin. It's classic. They'll turn purple, then they convert from purple to reds to greens to yellows. And that process of time is all metabolically dependent on the child. That's why we can be so indistinct when it comes to bruising. I have a very tough time telling someone that a bruise, I can tell you it's old or I can tell you it's recent. That's about as far as I can go. Retinal hemorrhaging, the bleeding behind the eyes, again, in neonates, they examined, just to give you an idea, they did a study where they took neonates and examined it 1 week and dilated all of them, looked for retinal hemorrhaging. 15% of neonates born, normal children, have retinal hemorrhaging at birth. That's the kind of pressure the kids go through during the birthing process. So typically it will resolve very quickly, but can take up to 6 weeks sometimes. So if you have a 1-month-old with retinal hemorrhaging had a vaginal delivery, you have to be cautious about thinking that this is acceleration, deceleration. It could simply be the birthing process. So these are all things that we consider. There's a couple types of associations. If you see bruising of the chest associated with retinal hemorrhaging, it's a bad sign. And you'll hear this word called torsion syndrome. And what that means is that there's enough shearing, like with an acceleration, deceleration injury, that they actually, instead of the small veins breaking in the periphery of the retina, which we see when we look in the eyes, they actually will shear off the veins behind, and you get a hematoma behind the retina. That's a very bad sign. That's associated with significant acceleration, deceleration. Last thing I'm going to touch on is burns. And to give you an overview of what I kind of look at in terms of analyzing these cases. Child burn victims, about 10% of child abuse cases are burn related. 10% admissions to burn hospitals or burn units. And at Shriners Hospital, we had a big burn unit, were due to child abuse. Scalding is the most common type of inflicted burn injury. And the contact type is usually a branding type, i.e. A cigarette or something that's put directly, or a curling iron put directly to the child's skin. We talk about burns that are partial thickness or full thickness. Interestingly enough, full thickness burns are painless. You've essentially destroyed the whole layer of the skin and where the nerves are, and they don't hurt that much, which is kind of sad. The ones that hurt the most are the first and second degree burns. First degree burn, you think of kind of like a sunburn. And anybody who's had a really bad sunburn, that's the Hawaii talk I have back after that. If you get blistering, now you progress to a second degree burn. So second degree burns have blisters. And those are painful, but they usually heal completely. Third degree burns do not heal because you've lost the skin. So there's always going to be scarring with third degree burns. Hot liquid splash injuries, interestingly enough, a lot of times can be purely accidental, can occur. They characteristically have a very irregular border because as the different amounts of thermal energy transfers into different areas, and they'll have non-uniform death. As hot liquid runs down a child, it'll develop these little points. They call them arrows. So you can tell when someone was splashed that as the liquid runs down, it has a very characteristic pattern. And the burn is always worse when the child's wearing clothing that gets splashed with hot water or scalding water. Deliberate burns tend to have more of a uniform depth and very few of these water lines, i.e. the child is held in the water as the scalding is taking place. And again, accidental immersion is more variable dip. It's because as they touch something hot, they immediately want to pull it back. So, how long does it take to cause a burn? To give you an idea, it all depends on the amount of thermal energy that's transferred to the skin. So the adult data that they have, no one's thankfully done this in kids, it takes about 127 degrees Fahrenheit, okay? It takes about a minute to cause a burn. At 130 degrees, half that, and 150 degrees Fahrenheit, remember it's 212 degrees to boil water, 2 seconds to cause a burn. So the hotter the liquid, the shorter the duration or time it takes to cause that particular burn. And sparing is the key. Interestingly enough, if a hand is pushed into hot liquid, instinctively you close your fist. And so the palm is typically spared. Same thing with the soles of the feet.
What does the average hot water heater heat up to?
That's a great question. I don't know the exact, but it's somewhere around 135 degrees.
Oh.
It can be at least that high. And you should keep, the data suggests you always be under 120 if you can. Again, immersion burns, if they put a child in, they sit him in with his buttock, you'll have it looks like a little cylinder or a donut. The stocking glove patterns, the sharp demarcations, as I mentioned before. The contact burns, whether you put an iron on, curling iron, cigarette, etc. Cigarette burns on the back and buttocks are, interestingly, they don't back into a lit cigarette, typically. So you have a burn on the back of a child that's very, very considering a cigarette burn. Burns, obviously, burns around the face and eyes could be more likely to be accidental. But multiple cigarette burns is typically, especially at various stages of healing, is indicative of abuse. And ironing injuries, as mentioned, depends on branding effect, depends on the depth of the burn. Flames or hot objects, rarely do we see that. And accidental contact burns, as I mentioned, they're trying to get their hand away from that thermal energy, so you look for the sparing. So, quickly in my last couple minutes here, how do we do a workup? Interesting enough, I get a lot of information out of the petition. I don't necessarily believe the petition, I mean that in the most loving way, but it really gives the most concise allegation as to what happened, and helps us who review these cases tremendously. Obviously the jurisdiction, disposition reports, the detention reports are important, medical records are incredibly important, and when we look at this, or I look at it, I always look at for the ER reports, ophthalmology examination, bone surveys, and we classically repeat those bone surveys in 2 weeks, and I want to see the actual films. It's very helpful for me to see the actual films. Our radiologists vary tremendously. Some of them are fantastic, some of them are not as great. And so looking at the actual films can be incredibly helpful. So always push to get films to send it to the experts.
Those can be electronic, right? They don't need
Yes, you can put them on disc now. I used to hate that, okay? I'm an old guy. To me, I love holding up an x-ray, just something nice about that. But no, everything is done now electronically. And what's nice, remember, the problem is when we do electronic films now, I mentioned this, when you get a disc of films like from Children's Hospital or Loma Linda, remember, it's not like a JPEG file. It's not like taking a photo on your phone and sending it somebody's email. When you put the disk in the machine, you have to open up the entire disk operating system. It's very analogous to if you gave somebody a Microsoft Word document on disk, that you'd have to give them Microsoft DOS to install on their computer every single time. So it takes a long time to open up films on a computer this way. I one time figured out, in my psychotic mind, the average orthopedic surgeon sees between 3 and 5 discs a day of films. Each disc takes, on average, 57 seconds to open. I one time figured out that if there are 20,000 orthopedic surgeons working in the country, we spend 2 weeks a year of non-compensated time waiting for the stupid disc to open, when I could have just tossed the x-ray up and sent it immediately. So when you send me 14 discs, understand it's going to take me a long time to open all those discs. And so be sensitive to that. I do like the setting of the discs, but one would be nice. You can do bone scans. I used to do bone scans much more frequently because the nice thing about a bone scan, what a bone scan is that they found out that bone is made of a molecule called a diphosphonate. Is the main source building block of bone. Those diphosphates are constantly turning themselves over. And you can take a diphosphonate molecule and tag it with technetium, and you can inject it into a patient. It will go to wherever bone is turning over. And it's very helpful for us because if it's, especially in chest issues, is there a rib fracture, is there not, the bone scans are the most sensitive. The problem is that it's radionucleotide injection. And so we don't do it anywhere nearly as often as we used to. With more modern techniques, especially with the reconstructive techniques we have now for good quality CT scans and MRs, it just doesn't happen very often. So, fracture healing, we can tell you a little bit. The mechanism of injury, that's the key. What's the pathophysiology of how it happened? Not do I think it happened intentionally, because I'm not going to be able to tell you for one fracture. I can tell you for a pattern if it's more likely that it was inflicted, but I can't tell you really for one. And in, is the ophthalmologic exam key? The ophthalmologic exam is key for shaking, for acceleration, deceleration. So that's one thing I always look to. Bruising, I can tell you pattern, aging, associated injuries. Difficult to determine intent. We look for the pattern, and it's tough to rely upon poor witnesses. I can't tell you how many times, a lot of times, you read the, and I love the police reports, I really pay very little attention to now because the police are there, a lot of times they're taking down statements, and the parents either don't know, are afraid to tell, and the police, it's just not very helpful to me. So I rely a little bit more on the social worker statements than I would in the police reports. So in conclusion, you obviously have to verify the reports. One of the problems we get into in my business is that a lot of people take the shortcut. So when a patient comes in the ED, if the emergency room doctor says, I looked at the chest x-ray and there were 3 rib fractures. Well, that may or may not be true. Or I think there were 3 rib fractures. That gets translated to the next note on the chart saying there were 3 fractures. And then that gets translated to the next note saying there were at least 3 fractures. And so pretty soon you get in this telephone game when you read the medical records. So the key is to get to the original source information first. Get all the data, the labs, the films, the imaging, try to determine what the forces were, try to build a timeline, and just to add information, not advocacy from my point of view. All right, I know I threw a lot at you. Any questions, comments?
I have a question.
Yes.
So for brain hematomas in infants, you were saying that they're most commonly caused by the child, someone dropping them essentially, right?
Skull fractures for sure. That's the most common reason. If I see a child that has a very classic, I have a child with a parietal skull fracture, parents don't know what happened, say it couldn't, have no idea when it would occur, child never ever fell, except maybe fell 6 weeks ago and hit their head. So you know with the soft spot that's not true.
Okay.
In all likelihood, somebody dropped the child. Now, when it comes to subarachnoid bleeds, it's very common to get a subarachnoid bleed or hemorrhage if you have a fall or hits the floor, because there's enough of that shearing injury, but you typically you won't have the retinal hemorrhaging from that repetitive back and forth.
So it's unlikely, just out of curiosity, to be caused by another sibling then? That's a...
You know, a sibling can shake, a sibling can drop. It's fairly common for a 3-year-old to want to pick a baby up and drop the baby on the floor. Maybe it's not common, but I'm sure it happens.
Right.
So I always want to know there's siblings in the house. And do siblings have access to the
Right.
baby?
Okay.
That's always helpful.
Okay.
Yeah.
Doctor, first of all, before I ask my question, I want to thank you, because I don't know if you realize over the years how you've educated us, how you've helped our client, and probably more important than even helping our clients, you have raised the knowledge of medicine amongst the judges and have really had a profound effect on dependency law in the county of Los Angeles. So thank you. My question is as we learn more about genetics and whether it's racial, ethnic, gender, whatever, when we actually look at bones, if we're talking about something like brittle bone disease, let's say it's not a pathology, there's no identifiable pathologies, are there studies to show that maybe there are different genetic variables or variances in bone structure that might affect breaks?
No, you're exactly correct. Yes. And by the way, when it comes to quote-unquote brittle bone disease, understand there are 56 different gene alleles that are known to have some effect on bone fragility. And we know for a fact those probably only count about maybe 70, maybe 80% of all of them out there. We just don't know the others. And you're right, there are families that fracture. There are families that fracture as children but don't fracture as adults. And our sophistication is not quite to the point where we can, the 23andMe thing where you take your kid and you send it off, find out if they're going to break bones. But eventually, I'm sure we will get to that level. But and when you see these kids in these families, they all have some characteristics. They have teeth issues. They have blue sclera from their dentition, and a lot of them, I've stopped advocating sending off genetic testing for osseous imperfecta because, to me, it doesn't really help. In those cases that they simply are easy to spot, and they're going to be positive when you send them to Seattle. And it costs a lot of money to send them to Seattle for the one lab in the country that does it really, really well. And if it's negative, they'll send you back the report and say, we can't say it's not. We can just say, we just didn't find it in our 56 we tested. So from that perspective, you are correct. I think the future of this business will be identifying those kids in cohorts that are most at risk, and maybe we can help influence how they're taken care of in the future.
Can I just follow up with one question? So as the attorneys, when we're beginning to get information or talk to the client the first time, would it be an important thing, just as we ask, like with the newborns, was it a traumatic birth, was it not? Should we be asking, when you were a child, is there a history in the family?
You are absolutely correct. You should ask, was there a history of fracture? Especially when you look at someone and see that bluing of the sclera, which is pretty impressive seeing, and there's a lot of patients that have that. And ask them about their fracture pedigree, their fracture history. You're exactly correct.
What's bluing in the sclera?
What happens is that there are bones, and most of our tissues are made up of collagen. Collagen is it's a spiral helix of proteins. And there's a type of collagen, which is type 2 collagen. And that collagen, if you have an abnormality in type 2 collagen, instead of looking at someone's sclera, which are the whites of the eyes appear white, it looks dramatically blue, kind of like like that shirt. It'll have this color of blue. Oh, blue there, huh? It'll be that color blue. Very striking. And there are a lot of actors, actually, believe it or not, that have this because it gives them a very striking appearance to their eyes. David Thomas, who's a big comedian, if you ever see a close-up of his face, he's got the most striking blue sclera. And he had multiple fractures as a young child, fractures less frequently now. All right, guys, well, I appreciate the time to come and chat with you.
Thank you very much.
Oh.